time to get started. We start at 10:30, don't we? All right, good morning, everyone. We'll get started right away. We're already at 10:33. So good morning. Welcome to our session on the opioid crisis, past and present. I'm Leslie Warren. I'm your room moderator for today. My job will be to make sure that the speakers do not go over 1 hour, because we know that lunch is next and nobody wants the speakers to go over 1 hour. My job will also be to make sure that when we get to the question and answer, that whoever wants to speak will have a microphone, because we are streaming, so we need to make sure we pick up the audio, and we are recording for people to watch later. It is my pleasure to introduce our two speakers for today. Dr. Russ Magnaghi, who is Professor Emeritus at Northern Michigan University in History. Many people here know Dr. Magnaghi already because he has been the leading expert in our regional Upper Peninsula history for many years. He's also the historian for Northern Michigan University. Russ has written quite a few books about UP history. I'm not going to try to give a number, so I can make up a number. I'm going to say it's something like 532 and a half. But is that close? Pretty close. Okay, there we go. And so Dr. Magnaghi, of course, is Professor Emeritus. He is retired from Northern, but obviously still active in the scholarship of Upper Peninsula history. Presenting along with Dr. Magnaghi will be Dr. Michael Grossman, who is a practitioner medical doctor in Magnaghi. Dr. Grossman is the medical director for Great Lakes Recovery Center and the director of the Medical Assisted Therapy Clinic at Great Lakes Recovery Center. He is also a hospice practitioner and is the, I'm going to mess up that credential, so never mind. We'll forget that I said anything. Dr. Grossman has been in practice since 1980. I will turn things over first to Dr. Magnaghi then. Thanks, Russ.
Okay, thank you for the introduction, and welcome to everybody. I'm going to be talking about a topic that I am safe to say has not been covered in the past, and that is the history of the use of narcotics, both medical and recreational. And I've specifically, my paper is Narcotics and Addiction in the UP, 1650 to 1950. Those are, in general, the area I'm going to be covering. But I found that nothing has really been written about this topic. I looked at a Michigan history book, and there were 2 sentences about, and it kind of boiled down to, we have a problem in Michigan. Amen. And I'm always looking for new topics, and when I get into these topics, it's I'm in the process of educating myself, and that's what happened here. Now, so what you're hearing is information for the first time, and I've tried to focus on the UP, but I've had to kind of go beyond, and you can kind of piece, what's like today, what's happening in the country comes back and happens in the UP as well. We all drive cars. Okay, you get the idea. Now, kind of the lay of the land. What are we talking about? The narcotics of the past are pretty much those of the present. There was opium. Then it was also referred to as landanum, morphine, cocaine, and heroin. And these drugs were used for medical purposes, and then kind of after the Civil War, they got, and we'll see why, they got into recreational use. The topic I'm not going to get into because it would be a topic of its own, and that is alcohol addiction. And alcohol addiction goes back to the early settlement of the UP when liquor literally flowed through the through the St. Mary's River in bottles coming up into the UP. But it actually went back to the French fur traders who pretty much addicted the Native Americans the French to brandy, and then the English came and addicted them to rum. But the first question is, when did opium arrive in the Upper Peninsula? And we find that the French introduced it in the 17th century as a medicine. The French fur traders, the missionaries, soldiers, and so on, carried with them a thing called theriac. Theriac kind of went back into the Middle Ages, and it was a mixture of heavy on the opium with a mixture of spices. And obviously, they could pass this out, and there would be a rather instant cure for people. And you have to remember, at this time, when you get into medicine of that time and into the early 19th century, there really wasn't much that you had that was available. So the opium solved all medical problems, and it continued to be used by the British, the early American military, and so on, especially at Mackinac. Now, you have to remember that opium and morphine were both readily available to the public. We have newspaper items from 1834 coming out of Detroit. A company, Chapman and Owen, pointed out at that time they had large stocks of drugs and medicines at low prices. 1840, there was Hamilton's elixir of opium that was readily available. And by the way, these items cured just about everything. Headaches, lassitude, tremors, nausea, vomiting, constipation, derangement of the nervous system. And then you had, in 1856, you had the introduction of the hypodermic needle, which will then bring us an entry into morphine. But you find that it's just amazing when you look at the ads, how readily available, and it was being, these opium and morphine, strychnine, were being readily advertised in newspapers in Detroit, in Chicago, and you have to remember that isn't the UP, but it's from those cities that you have goods coming north and coming into the Upper Peninsula. You're going to find, though, that you begin to see, like in 1845, there was a newspaper article saying, talking about, quote, the lasting and tormenting effects of calomel, opium, arsenic, and the deadly scientific drugs of the earth. So at that point, drugs are, especially opium, are coming into the area, but for medicinal purposes. Then the Civil War comes, 1861 to 65. 12 million capsules of opium are given to Union troops, and the opium was available for wounds and so on. But also not a cure, but a remedy for diarrhea and stomach ailments and so on. And that diarrhea was a major problem. And you can read about narcotics being smuggled into the South and so on. And the South even talked about raising opium poppies and making their own opium. Now, what happens is, if you have 12 million capsules going out, people are the soldiers are using it for more than medical purposes, and as a result, you have a outbreak then after the Civil War, and this can be seen in even Upper Peninsula newspapers, you can begin to see the spread of opium use and morphine use for recreational purposes. And you also find that in the 19th century, and there's a very interesting article that I ran across, but women, and the article ran the years 1850 to 1920, but women made up 60% of opium addicts. And this was opium that was taken for menstrual ailments and related, as they call them, female problems. But it was taken quietly by women, and few people, even at the time, recognized this was happening, was a problem. So that's kind of an interesting development centered around opium being used for medicinal purposes. The use of opium and morphine was supposed to be through physicians, but you had numerous problems with overdoses. Sometimes it was taken for, especially the morphine was taken to commit suicide. You also had some tragic, and this comes up frequently in the newspapers, you had tragic accidents where people grabbed the wrong bottle and gave their kids opium instead of some other cough medicine or something. And that comes up frequently. We have in 1910, there was a Hancock druggist who ran into problems, financial problems and so on, and decided to solve them by committing suicide with morphine and having his wife join him. Well, luckily she didn't take enough of the morphine and survived. He didn't. Also, you find that physicians in the country, and this would certainly be in the Upper Peninsula as well, 1 in 10 physicians were addicted to morphine at that time. In the 1870s and 80s, as I said, the post-Civil War period, medical journals begin to be filled with warnings about the danger of morphine addiction. 1876, I think it's a Escanaba newspaper, talks about morphine, as they called it, morphine eating, and how, and this is something that happens today, how doctors are giving prescriptions for the use of morphine. It was soothing, it took care of physical pain, a person had an injury and so on, then the pain reoccurs. Morphine is resorted to without proper prescription. You have to remember at this time there are no regulations. Through much of the 19th century, there are no regulations where you had to have a prescription. You just went out and bought it. I found that even the newspapers in Detroit and Chicago in particular had like the market price for goods. And morphine and, quinine, morphine, opium were out there as a commodity. So to be like looking at our stock market today and seeing morphine and opium being available. And there are all sorts of stories. Some addicts were so into it that you were only supposed to, if you're going to take morphine, you're supposed to take, they talked about grains, and I can imagine, little grains of it. And one doctor gave some opium to a fellow. He wanted an ounce of it. These are a lot of grains. And before he leaves the office, he unwraps the thing and takes the full ounce. And the physician thinks he's trying to commit suicide. And he asks him what happened. He said, I need that. That's the minimum that I'm able to take and have an effect on me. and so on. And you also get some of the newspapers, especially like out of Escanaba, going into details about the use of drugs at this time. And there was this one interesting statement: the pleasures of Elysium, heaven, when under its influence of morphine or opium, under the influence of a customary dose, and the horrors of Hades when deprived of it. So they began to see, very early, that these drugs had a terrible impact, and you'd become addicted. There was one fellow, a teamster, that was hurt in a struggle. He ended up selling his coat in the middle of winter so he could buy drugs, and he said it was he could survive the rigors of temperatures below zero, as they were less painful than the horror of being deprived of his daily dose. And so you see they go into a certain amount of detail about taking it and the problems. The quantities of opium entering the United States is going to be quite high. In 1875, the United States imported $829,000 worth of opium from China. Today, that would be about $206 million in opium. And by that time, by the late 19th century, the opium habit, morphine as well, prevails in the United States. There were some. You can see that there are, by looking at the newspapers, you can see that there are problems in the Upper Peninsula, even though there aren't news stories, because if some, Joe Dokes down the street is taking opium, it's not going to make the newspapers, but you do see it in advertisements. And in the 1870s, 1875, for instance, Escanaba Tribune is an example of it. There was a Dr. Beck's only known and sure remedy for a speedy cure from opium. So you had various people, physicians and so on, at a distance and so on. And this Dr. Beck from Cincinnati said that in the ad said that there'd be no charge for treatment until you were cured. And these ads continue: opium habit cured. I claim to have discovered and produced the first, original, and only sure cure from opium eating. Dr. S.P. Collins, LaPorte, Indiana. And this goes on. There was a Dr. Keefe's Institute that started in Illinois, and then they were going to spread the operation, and it was to cure people of opium eating and alcohol. And they were going to open, in 1892, they're going to open a outlet for recovery in Marinette. Eventually, it opened up in Grand Rapids. Dr. Miles' restorative Nervine, and you'd get a free bottle at the drugstore, and this Nervine thing cured all forms of neuralgia, spasms, fits, sleepishness, dullness, dizziness, opium habit, drunkenness, epilepsy. And they pointed out, in case you were worried, which was always a problem, it does not contain opioids or dangerous drugs. In terms of the UP, Sault Ste. Marie, and I won't go into all the details, but opium entered Canada through Victoria and Vancouver, British Columbia. When the Canadian Pacific Railroad was finished, it would then pass through Canada, dropping down into the United States. And one of the drop-off points was Sault Ste. Marie. and drugs then crossed Sault Ste. Marie. The soldiers at Fort Brady, many of them were taking opium, morphine, and cocaine at that time. I should also point out that cocaine was rather commonly used in the late 19th century. We have Coca-Cola. There was a reason for naming it that. It had some cocaine in it, gave you a little perk. And in terms of ads, Queen Victoria and Pope Leo XIII had advertisements to take various wines and drinks and so on that had cocaine in them. So that was rather common. Today I've kind of focused just on the opium and morphine, but you had a lot of activity through the Canadian Sioux and also through, at that time, Port Arthur, and well, now it's known as Thunder Bay. The other and I'm going through this very quickly. At some point, I'm gonna put together a little booklet because there's so much information you can't do it all at once. But another item that became and would also then get you addicted were patent medicines, and patent medicines were, especially in the beginning, filled with opium. I mean, cured everything, but they were giving these patent medicines to babies that were teething. The kid's crying, and well, give them a little shot of this preparation, and it was there was a sort of an older woman that kind of fit the situation, and she offered Mother's Comfort, and it was a syrup for small children. It had a 0.14 of a grain, so it had a certain amount of morphine in it. She went on trial, and the prosecuting attorney said, well, that's bad for babies, to be taking this stuff with morphine, but any kids over 12, it's fine. So this is, you begin to see, this is kind of a wild world of drugs. And one of the newspapers carried a list of 12 medicines that were readily available, and then indicated what was in them. And they had morphine, they had strychnine, morphine, opium, were all part of these medicines, and many of them used for children. The Calumet, 1897, the Calumet News had an article about taking cocaine for seasickness because it would dull your stomach. It pointed out that General Grant, who was a big cigar smoker and was suffering from throat cancer, he took cocaine to relieve his pain. And this one, maybe I shouldn't mention it, but firemen in New York and Chicago, and probably to a certain degree in the UP, would take cocaine, and however they did it, put it in their eyes so that the smoky, it gets worse, so that the smoke wouldn't bother them. And there were some people at that time that put it in their eyes so that they could have their eyes tattooed, color tattooed to their eyes. So it was before contact lenses. I'll just kind of sum up some of these details. The states began to, there was no federal law against narcotics and so on. States began to pass various laws, except I cannot, even online, I have not been able to find when the state of Michigan began to pass some laws controlling the sale of narcotics and so on. In 1914, the Harris Narcotic Act was passed. In the federal law went into effect in 1915, and that began to have, well, on one hand, it was supposed to have control. Actually, there was it controlled the amount, and it seemed that more people began to take narcotics after that time. We have, to bring the story to campus here, we have, I interviewed this very, very old woman years ago, and she was at Northern around 1915, and at that time, the music instructor took drugs. This is what she related. And then I talked to another woman whose mother is 107, and she pointed out that when her mother went to Northern in the 1930s, her mother and the other students were kind of in a state of shock that drugs were, drugs were being taken. As we get into the 20th century, we find that the use of drugs is widespread in the country. It goes on in the Upper Peninsula. You had various people, speakers, talking to Masonic groups, Rotary clubs, Kiwanis clubs, Knights of Columbus, anyway, civic clubs that way, trying to alert people to the problem. And by this time, drugs are being taken by high school kids who are then spreading it to other kids. And what I would have to say is that for some reason, I hadn't really gotten into this topic originally, that you hear about drugs and so on. And I thought this was something that was kind of, from my lifetime, from the 1950s or something, we had drug addiction and so on. And all of a sudden, as I got into this project, this has been an ongoing problem, certainly into the 19th century. One of the interesting things that occurred, and I haven't pursued this one, but a lot of the bootleggers and the Al Capone crowd and so on found that they could they would have fewer worries about competition, about the police and so on, instead of driving a huge truck loaded with Canadian Club whiskey down to Chicago. They could take a little bag of drugs for the same amount of money. So to a certain degree, prohibition then encouraged the development of drug usage and so on. So it's a very, very complicated topic. And what I wanted to do today was just bring that topic to your attention. And as I said, right now I have about this much information that I've gathered in a file dealing with narcotics and drug addiction, covering what I've said today. So I'm just hitting the surface of this topic, and I don't know. Maybe we'll have I'll step aside and we'll have the other paper given, and then if there are questions, we can both answer them for you. Okay. Thank you.
I guess I can take my mask off. Thank you very much, Russ. That's very interesting. Having been treating people with opioid addiction now for many years, I'm not surprised that it was around in the 1800s, because it's a naturally occurring substance. Poppies, morphine, heroin. It's a much worse problem now. I'll talk about like the last 20 years, and. When there's questions, I have to recognize my colleague, Dr. Maynard, is here, and he's probably prescribed as many opioids as I have for analgesia, which is for pain, which is mainly why we use them in the medical field. So opioids, what are they? Opioids are substances. Some of them are naturally occurring, such as morphine. Some of them are synthesized, such as fentanyl, which I'll be talking about in a minute, which is killing people at a pretty high rate. But they're generally used medically for pain. I have in my handout they're used for analgesia, which is pain. We don't use them to induce euphoria. That's why patients take them. They get pleasure, they feel happy, they're relaxed, they feel high. So in the medical profession, we use them for pain. We also, unless you're in hospice, you might not know this, but they're very effective drugs for shortness of breath. So people that have COPD or any kind of lung problem or congestive heart failure, when they come into hospice, that's the first drug we use, morphine. We use it for pain, but we use it for shortness of breath too, so it's very effective there. The undesirable effects, it always causes constipation unless you do something proactive about that. It can cause confusion, but it kills people by depressing their respiratory drive, and then they stop breathing. So that's why it works for people with shortness of breath. They don't feel like they're short of breath anymore. If we use the right amount, it's not going to kill them. But if people take an overdose, as they are doing on a regular basis now, especially with this drug fentanyl, it's killing a lot of people. I don't have specific data from the Upper Peninsula, but as Russ said, it's what goes on here is a reflection of what's going on in the country. I just didn't know about this talk till it was too late to get that. There's a doctor named Dr. Kevin Piggott. He used to run the health department, and he has a lot of data about the Upper Peninsula. But I didn't really have time to get all that. But I have been treating patients at Great Lakes Recovery now for opioid addiction probably for about 12 years. So I kind of know how things are going here. I treat people both inpatients in recovery and outpatients. So, how do people get addicted? Well, initially they take the drug, they're given a prescription, or they just take it recreationally, an opioid, either to relieve pain or to get high. And what happens is if they keep taking it on a regular basis, they do get addicted. And this is something I didn't realize. The reason they need to take it all the time is not that they necessarily want to get high all the time, which I'm sure that's a benefit, but they keep taking it so they won't withdraw. And when you stop taking opioids, alcohol, nicotine, all that stuff, there's unpleasant withdrawal. And in the case of opioids, if you stop taking opioids abruptly, you feel like you've got the flu, the respiratory flu, runny nose, severe aching of your joints and your muscles, and you also feel like you have an intestinal flu. You get vomiting, diarrhea, and on top of that, you have severe anxiety. So you're very anxious and agitated, and that's how a patient that's withdrawing from opioids. So in order to avoid the withdrawal, they need to keep taking it. So that's part of the addiction. Generally, they never get the high they initially had. They just keep taking it so they don't withdraw. It's very unfortunate. How does it do this? Just briefly, the neurobiology. Opioids cause a release of a neurotransmitter called dopamine. That's kind of a feel-good hormone. So when you have a really good meal, you get a dopamine release. If you're a runner or an athlete or you like exercise and you have an exercise session for an hour, you come out feeling really good, that's dopamine. And dopamine causes the release of endorphins, another hormone that makes you feel good. But you get much higher levels of dopamine and endorphins with heroin than you do or morphine than you do naturally. It's released from a part of the brain called the mesolimbic system or the reward center. And what happens is once that gets going, it can't stop. We have another area of the brain, which is the executive control center called the prefrontal cortex, the thinking part of the brain, your conscience or whatever. And once the brain gets going on morphine or heroin or fentanyl, those connections between the thinking brain and the reward center are severed. So you're running on your mesolimbic system, not on your thinking system. So people that are addicted to opioids, it's a brain disease. Their brain is not right. You can't just tell them what's obviously logical. It won't make sense to them. They're running on opioids. Let's say OxyContin, because I'm going to talk about that in a minute. Now they don't call it necessarily addiction. They call it opioid use disorder. In the handout, I forgot to put what it stands for, OUD, opioid use disorder. And to be addicted, you have to have more than tolerance, which is meaning taking more of the drug to get the same effect. You have to have that. You have to have dependence, which means if you stop taking it, you'll withdraw. But if you just have those two elements, you're not necessarily addicted. You might be taking opioids for chronic pain and taking it exactly like the doctor wants, and all other aspects of your life are going okay. So you're not addicted. But to have opioid use disorder, you usually have those two, plus at least one of the following that I have in there. I'm not going to read them all, but one big one would be cravings. You crave the drug. So if you're just taking it for a chronic pain and it's helping your pain, you're taking something, say, 3 times a day, but you're not craving the drug and everything else is going okay, you're probably not addicted. But if you're craving it, that's a bad sign. If you're taking higher doses than you'd like to be, or to get the desired effect, that's not a good situation. If you're using it in dangerous situations like driving, if it's causing social disruption with your wife or your kids, that's a bad sign. Job problems, you're unable to stop or even cut down, another bad sign. And maybe you're giving up other enjoyable activities that you used to like, say golfing. Well, I don't need it. They just stop doing it, or they'll stop exercising mainly because they'd rather take the medication. And then, of course, using the drug despite the knowledge that it's harmful for you. That doesn't really matter to people that are addicted. Again, it's part of the brain disease. So if you have 3 or more of these, then you probably have an opioid use disorder. If you have 6 or more of those, it's severe. Now I want to just talk a minute about, I want to keep my eye on the time, but I think we have plenty. You talked about, I don't know, 100 years span, Russ, from 1850 to 1950. I'm going to just talk about the last 20 or 30 years. So there's been and I want to talk about opioid deaths, because that's something we really want to try to avoid, and the number of deaths just keeps going up every year. So in the first wave of deaths, 1999 ahead to 2010, it was us guys, the physicians, you can disagree with me, we prescribed too many opioids, and people got addicted. And I'll tell you why in a minute. It wasn't because we wanted to get people addicted. And people were dying of these prescription opioids. Then we were told, docs, slow down, we're prescribing too much. People are getting addicted and they're dying. So doctors took heed and they stopped prescribing so much opioids. So I thought for sure the death rate would go down then, but it went up. Why? Because the patients started taking heroin off the streets. So a lot of patients that were getting it from their doctors got cut off. Well, they don't want to withdraw. They didn't have a lot of options. They weren't offered treatment, so they started using heroin. The third wave we're in presently, it's the most dangerous wave of all, 2016 to present. And this is kind of a combination of, we don't have so much cocaine in the Upper Peninsula, at least in my experience, but we have a ton of meth. So a lot more people are being treated for their opioid addiction, but they're still using meth because we don't have a really good way to stop them. And mixed in with the meth, unbeknownst to them, is a drug called fentanyl, which is a super potent opioid, 50 times stronger than morphine. And they're dying from it. I would say in the UP, I don't think we have the fentanyl problem that the rest of the country does. It doesn't seem like it to me. I'm not hearing as meant, but you'd have to talk maybe to law enforcement or maybe to pathology. I don't think we're seeing as many fentanyl deaths, but we're still seeing plenty of opioid deaths. People are still ODing from meth. And one thing I'd like to say about methamphetamines and cocaine, they're not actually opioids. They're stimulants. But they're just as bad, if not worse. And right now, many, many people that used to be addicted to opioids have changed to meth. And I'll talk about that in a minute. So if you look at the death rates, back in 2000, about 18,000 people died of opioid overdose. And it just keeps going up, even though the doctors quit prescribing it so much. I mean, the doctors will do what there's science behind it, and the science became apparent we were overprescribing. But in spite of that, it's quadrupled since 2000. And now 2020 was the highest year yet. Probably a combination of this fentanyl with methamphetamine and also the COVID crisis. Isolating people. Social isolation is a big risk factor for opioid addiction. And we got a lot of that here in the Upper Peninsula, too. So this was the worst year, actually, 2020. We don't have statistics on 2021. So why did this happen? Well, there's not one cause, but I want to, in 1988, there was a editorial in the New England Journal of Medicine, which is probably the most famous medical journal, respected medical journal in the world. It's published in Boston, the New England Journal of Medicine. And there was a editorial, which I might have read at the time, I don't have it with me, and it basically reviewed thousands of people that got opioids, like morphine, in the hospital for their pain, and their conclusion was hardly anybody gets addicted. So doc, treat the pain, don't worry about addiction. And it was just an editorial, it wasn't even necessarily a study. They looked at some studies, but it was poorly done, and the person that wrote the article, I think, is still alive and regrets ever writing it. But after that, opioid prescriptions took off, and in 1995, a drug called OxyContin was made by Purdue Fredrickson, a company now which doesn't exist. But they convinced all the doctors that you have to treat pain, treat it with narcotics if you need to, and that pain became the fifth vital sign. So in medicine, we talk about pulse, respirations, blood pressure, temperature. They started putting a little in the hospital. You had a little extra thing for pain. Ask about the pain. Ask about the pain. And to make things worse, they had physician surveys, and if the surveys came back that the physicians weren't treating the pain adequately, you could actually get docked on your pay. They could take it off your salary. I don't think that happened widespread, but the threat was there. Nobody wanted to have a bad survey, so the ER doctors started prescribing more opioids because of that. So in 2010, physicians started to realize that they were overprescribing. The death rate was going up from opioids. And then in 2013, life expectancy in the United States started declining for the first time in a long time. I mean, we've all heard that longevity keeps going up and up because of medical progress, because of sanitation, engineering. Well, it started going down, and it's been going down, and now the last couple of years, partly because of COVID, too. So that kind of woke us up as well. And then in 2016, the CDC recommendations about treating patients to doctors be very cautious about using opioids to treat chronic pain. Now, we still use opioids to treat patients that have chronic pain, but we're much more careful. And for some people, I think it helps, although the studies, when they actually study it, it doesn't work very well. You know, opioids help acute pain, but they don't work so well for chronic, what we call non-malignant pain. So people without cancer, or people, I'm in hospice too, and we use a lot of opioids in hospice, and they work great. It doesn't have to be cancer. But for people that have chronic pain that are expected to live 20, 30, 40 years, it's usually a bad choice. And that's what we've learned the hard way. So anyway, I work at a clinic called, it's called MAT Clinic, Medically Assisted Treatment for Opioids. And just to tell you, we use drugs and often opioids to get people off their opioids. So it sounds like kind of a bad idea, and I'm a family doctor. When I first heard about it, I was very skeptical. And a lot of my colleagues actually still are skeptical. But when they actually did the studies, when you put people on these drugs that are addicted to opioids and they're medically supervised, they have a much lower rate of getting back into their drug, of relapse, that's what I'm trying to say. So traditionally, we've been treating people, we get them off the opioids, and we have a residential center in Marquette. We still do that. We don't use drugs. We help them with their withdrawal to get off their drugs, and then we offer intensive counseling. I'm not a counselor, but drug counseling, psychotherapy, and treatment of their underlying psychiatric disorders, because about half the people, or maybe more, that use opioids illegally also have psych problems. But unfortunately, it doesn't work. So what they've found is that over 90% of people that are treated with 12-step program, I'm not talking about alcohol, I'm talking about opioids though. 12-step program, treated with psychotherapy, all the different relapse within a year. It's over 90%, probably about 95%. Now you might say, well, I know of entertainers and people, the guy in the Rolling Stones comes to mind. I don't know. I know that he had an addiction problem. I assume he stopped or he wouldn't be alive. What's his name? Keith Richards, yeah. So, although he might be taking something, I don't know. But we hear of all sorts of people that get off their opioids, and it's true, they do. But 5%, even 5% of a lot of people, there's 2 million people addicted to opioids. It's still a lot of people. But we have much more success, what I'm trying to say, is with medically assisted treatment. So what is it? I'll just talk about it for a few minutes. We use medication so that they stop using their other opioids. Now, the 3 medicines that are currently being used, methadone, which is a full opioid agonist. It's another opioid. It seems counterintuitive to use it, but it's long-acting, and it's been successful when patients use it under medical supervision. We don't have, until recently, there's no methadone clinics here in the Upper Peninsula. I understand now there's one getting started in St. Ignace. But I use methadone in hospice, but I don't use methadone for people that have addiction. So I can't talk too much about it. But there has been some success. Another drug, which is not an opioid, not a narcotic, is called naltrexone, and the IM form once a month is called Vivitrol. And then the last one is buprenorphine, which we usually combine with another drug called naloxone. It's called Suboxone. And that is a partial agonist, a partial opioid drug, which has been very successful when used properly in treating addiction. Now, can people get addicted to Suboxone off the streets? Yes, they can. But they're not being medically supervised, just as they can get addicted to methadone. So I'll say a few things about naltrexone and buprenorphine. Naltrexone it looks very good because it's not an opioid. You can't get addicted to it, and you're not going to overdose on it. It's got some side effects, but they're mild. So it blocks the opioid receptors in the brain, and it decreases the cravings for opioids. So those are all good things. Minimal side effects. The problem with it is if you try using it on someone who's recently got off opioids or who's taking opioids, by displacing the opioids from the receptors, they'll go into severe withdrawal. So you can only use it if a patient has been totally taken off the opioids. And practically, as an outpatient, we don't see that. Almost all the patients I see are already taking opioids. So I can't offer them this Vivitrol because they'll go in, and they don't want to stop cold turkey because they'll have terrible side effects. So I don't use too much naltrexone, but we do use some. We've had some success with it. You can actually use it for alcohol withdrawal too. And there's been some recent studies that maybe with another drug it might work for meth, but that's not proven. It's not approved yet. So then buprenorphine is what I use, combined with a drug called naloxone. That's called Suboxone. So that's a partial opioid agonist. It does decrease cravings greatly, but it is still possibly addicting. We don't take it orally. It's kind of hard to OD on because after a certain dose, it just doesn't seem to have more of an effect. If you combine it with a drug called naloxone, that's what Suboxone is, and they try to inject it, they probably won't OD because naloxone displaces the buprenorphine. I hope that's not too technical, but anyway, we use Suboxone because it's not generally injected. Now these people that are addicted they'll do anything. So they do try to inject it, but if they inject it, they'll withdraw, and so there's a safeguard there. So we don't see as many overdoses. We do have to be careful because people can still get addicted to it and take too much and quit coming to us and buy it off the street. But we've had very good success. How much success? Well, in terms of, we're treating currently, myself and another practitioner, about 120 people, mostly from Marquette County. And in terms of them relapsing to other opioids, very successful. I'd say 80 or 90%. But the problem is it doesn't keep them from using meth. So we have a lot of patients that still use meth. If they are addicted to alcohol, they may continue drinking. So overall, it's about 50% successful, but that's way better than psychotherapy and 12-step alone. The best thing is to use it with psychotherapy, drug counseling, and there you get your best results. Okay, last of all, I was asked to talk a little bit about, treating in the Upper Peninsula. What are some of the obstacles? Well, the obstacles, the Upper Peninsula is large. Up until recently, there haven't been a lot of people that treat for MAT, but that's getting better. So all over the Upper Peninsula, there are providers that can provide Suboxone. That's gotten better. But you still have transportation problems because people live far away. You have a lot of unemployment up here in the Upper Peninsula, some housing problems. We don't have as many people living on the street, but you'd be surprised there are a lot of homeless people that have to go to shelters. They can't afford sometimes their utilities, their bills, food. They can't afford, very few of them have a primary care physician they can go to because a lot of them have a lot of other medical problems and psychiatric problems. So these are all problems, and we have something now at Great Lakes called Opioid Health Home, OHH. And it's basically a recovery support service. And it deals, so if I'm seeing a patient and they're not doing well, maybe they're still doing meth, I ask about a job, they're not working, they don't have any place to live, I can refer them to Opioid Home Health, and they deal with all these problems. They try to get them housing for them, they try to make sure that they're properly fed, all those type of things, that they get to their appointments. We can give them rides to their medical appointments, not just to my clinic, but also to their primary care, and then get set up with a primary care provider. At Great Lakes Recovery now, we have a nurse practitioner that does MAT, and she's also in primary care. And if I have patients myself that just can't get to a primary care provider because maybe they burned all the bridges by taking too many opioids, I'll generally see them I'm a family doctor, so I'll generally help them out there. But this Opioid Home Health service is really good. Right now, it's only for Medicaid patients, but certainly it's not just Medicaid patients that get addicted, but we have a large volume of them, probably 60, 70%. So we can help them out. If they're not on Medicaid, it means they have private insurance generally, so they're not in quite as bad as straits. The biggest problem I find, besides meth, which they tend to use, is if they continue with their old friends that use and their family members that use, you're really fighting an uphill battle. They need to, and if they lose all their friends, they become isolated, and that's a risk factor too. So it's a struggle to make new friends, to meet people that are not using all the time. Yes, I'm right. I think that's all I want to say right now. In conclusion, I would just say that opioid addiction is a problem that I think we're getting a handle on treating it here nationwide and in the Upper Peninsula with these MAT clinics. MAT works better than psychotherapy or a 12-step alone, but combination is the best. So I think that's all. If there's questions, we could both answer questions here.
Thank you very much. I have a question about wild lettuce, otherwise known as opium lettuce, that grows naturally in town. Do you have much experience with that?
No, I've heard of it. What's it called again?
It's called wild lettuce or opium lettuce. It's a naturally occurring weed that grows in town. I was wondering if you have much experience with that. Okay.
I know that people use kratom a lot. I don't know if you've heard of kratom. You can buy it in the store. And in low doses, it kind of acts like opioids, and in high doses, it acts like meth. So we check for it in the urine. Just because it's legal, we don't allow them to use it. Or sometimes our patients think, they're smoking marijuana, and we try to get them to cut down or stop that. They're using alcohol. And they'll say with marijuana, well, doc, I can use it. It's legal now. I say, well, alcohol is legal too, but I don't want you drinking alcohol, so that doesn't work. Yeah.
For the purposes of the video, I do need you to be at the mic when you're talking.
Yeah, but you should come up too, Russ. They might have questions for you.
Are there other questions? Oh, hold on. It doesn't catch the camera for the recording.
Can either of you address the problem at the hospital in NICU with these babies that are the recipient.
Yeah, I can talk about that.
my
I don't
husband-
treat infants,
I
but
just want to say.
you're talking about the with neonatal withdrawal syndrome?
My husband and I rock, and once you see a baby coming off that, oh my goodness. So when you explain how.
Yeah, well, okay, well, mothers that are taking opioids during pregnancy, whether it's prescribed to them, they might be on a drug like Suboxone, or they may be taken off the street. The baby becomes dependent on the opioid. And so when they're born, they go through withdrawal, and they have the same symptoms that an adult would, but they don't say what they are. But basically, they have a surge of adrenaline all the time. So they're extremely irritable, crabby, and they don't eat well. I don't know if they get diarrhea or not, but
They do. They're
yeah,
gassy.
yeah, they probably get diarrhea. So, you know, they're miserable. And they were treating them, they still treat them, the babies sometimes with decreasing doses of opioids. But now they've found that they can treat them with just a very quiet environment, talking in soft voices, keeping the skin-to-skin contact, and a lot of them can withdraw without using opioids, a lot of the babies. And I'm glad you asked that question. I studied for my boards recently, and the doctor that has a lot of experience, babies are never addicted to opioids. She had experience with, kids come in. Well, I was addicted to morphine when I was born. No, they're dependent on it because their mothers took it. But they don't have that opioid use disorder where their social situation's bad and they have no control over it. They're not addicted. They're dependent. So there's no such thing as an addicted baby. Yeah.
Oh, hold on.
Yes.
I had no idea what you were talking about. It's like, I'm so glad I came here just to hear. But I think you mentioned, where did you first even get the idea that the Union soldiers were just eating opium, and in the French Indian War they were eating opium, and the American Revolution, where did you even think
Okay,
about looking?
I found that. Oh, let me take this off. I found that it was mentioned in a study of history of narcotics in general, and they mentioned the Civil War. And then I was looking at the paper, and I would point out that in today's world, the newspapers have been digitized, and so, and I couldn't have done this study without it. You can put a topic in, and you put the newspaper, and then you put the topic, and it'll give you all the articles in that newspaper. And when I put certain topics in, I got various news accounts of use of opium and so on during the Civil War. And so what I had read in general then came out in the newspapers. But it's a very and I've asked some attorney friend, could he get me information? He never got back to about the history of it. I don't know. Maybe I should ask the sheriff, but I don't want to ask anybody because I know the answer. They don't have any information about the history. Now, Greg Seibert can tell you about the problem today, and he was on TV Sunday, I think, talking about meth. And I guess we are one of the leading places in Michigan for meth. He was saying for meth use. I think it was also invented here. I shouldn't say this on campus. Way in the beginning, but that's another story. Okay.
As far as I know, most of the meth actually comes from Mexico, and I don't know why, but people are not making it so much. They used to make it, and sometimes they'd have an explosion or a fire and all that, but now it's so cheap, they're buying it, from Mexico. Well, they're not going right to Mexico, but they're buying it from dealers that get it from Mexico.
I know we at Rotary a while back, Matt Weesey went and came and talked to us, went into the details. He figured the Rotarians weren't going to get into making meth, and it was all of these topics give me the creeps. And what he talked about, meth and the chemicals that were produced and people could take, it was just horrifying. And yet people are, and then the meth has a physical effect on them. They just kind of deteriorate. Yeah.
We once had a substance abuser who he actually works for one of the recovery houses in Houghton now, or actually Calumet from Magnaghi. And when he said that when he heard about when he was using and he heard about how dangerous fentanyl was, because his brain was so messed up, he just wanted to use it. It didn't matter that it might kill him. He just really wanted to use it to see what the effects were. So, yeah, people will use anything. Yeah.
I just want to make a comment. Thanks, Russ, for reminding us about the effect of the Civil War, because on one level, opium addiction has been around forever. In China, etc. It's been with human societies for a long time. But it reminded me of the iatrogenic component, because in a sense that was the medical use, because there were so many people being injured and it was available, so it was being prescribed, and how that contributed to the growing social problem, you see what I mean, even afterward. But which is so mimicked by what we've seen, Mike, in just the last 30 years of practice, and how this, it's almost been like a pendulum between when pain is undertreated, and they said now it's overtreated, But I remember in the day also the medical profession was being criticized because there were so many, they pressured legislators and others. That's why they had that fifth vital sign added, because people complain so much about not having their pain controlled when we have these wonderful drugs around. So it's interesting that it's this interplay of an iatrogenic, I use that word because it's a medically induced problem, but it's also a social problem. And I think and we still fight this ambivalence. Are we dealing with how much of it is a physical problem we're dealing with? They're truly physically addicted, we should treat it as a disease. And then there's the other side of it, which is the social problem that's been around long before that was really an issue. So I'd just like to hear your comments back and forth and how we're going to address this issue, now.
Well, I can say, as far as MAT and using drugs to treat it, I mean, right now, at least the pet is that opioid addiction is viewed as a medical disease, just like I'm going to say diabetes. It's not just like diabetes. So, for example, my son has type 1 diabetes. He could have all the diet treatment and it's not going to work. He needs insulin. So what we're saying is these people that are actually addicted to opioids, we got to treat them medically. And right now, we have these 3 drugs, we should use them. I'm not saying something better might not come along. It probably will. But we look at it as a medical illness. And that also helps take the stigma of drug use away too, so that people aren't looked at as failures because they're using opioids.
And then we are
Disagree with you, Mike, but okay, I know the time's gone, but it's just that then you have to transition into the social problem to prevent recurrence. I agree, it's effective in terms of its treatment, but it's generally short term, and so the recurrence.
Is not short term.
Well,
We do it.
you do it for
we
years?
have no data now as to when to stop using it.
Okay.
And I can tell you as a practitioner, I've been doing it for 4 years.
Oh,
Very, very few people can stop using it.
yeah, it's a
But
lifetime
we
thing
still
then.
say they're in recovery as
Okay.
long as they're taking it as prescribed
Okay.
and living a pretty normal life, which it's amazing. Some of them, I have some people that have gotten master's degrees, gone on, but they still use. It's very hard to get off of. But if they want to, I always try to help them to get off. Yeah. But you're right. That's why I say that's where the counseling comes in, maybe 12-step and things like that. I'm not trying to discount the importance of that. Yeah, I mean, to just use medicine is, is too simplified. You're right.
So we are 7 minutes past